So we've talked so far about mast cells. Now I want to introduce you guys to eosinophils and basophils, which are also very important. So these cell types are typically found in connective tissue beneath the mucosa, and they often secrete cytokines that skew the adaptive response towards a Th2 response. They also contribute to airway tissue remodeling, and this is particularly important when we think about chronic inflammation from allergy. So in airways, we'll discuss this a bit later as well. If you have repeated antigen exposure, the airways can actually begin to deposit more collagen and they will be constricted. And these eosinophils can also release something called major basic protein, and this can actually contribute to more degranulation of mast cells and basophils. And so we have a nice summary chart here in figure 1410 showing the different classes of products that are produced by these cells, some examples, and the biological effects. So far we've mainly focused on acute immune responses. So that would be the response in a very short time frame after antigen exposure. So now we're going to be discussing that and contrasting it with chronic allergic reactions. So here in this figure you can see the difference between an acute and a chronic allergic response. And so here you can see in the immediate response, this patient has urticaria or some hives. But over time, as this becomes a more late phase response, there's increased swelling and this response will spread. So the immediate IgE responses are, as we've talked about, due to mast cell degranulation and lead to increased vascular permeability. And this can also lead to symptoms such as swelling or edema, skin reddening, and swelling of the airways. Then hives are actually caused by antigens that are brought to the skin through the bloodstream. An allergen in the bloodstream can cause what's known as anaphylaxis. So anaphylaxis is a severe systemic response that can lead to what's called anaphylactic shock. And this is widespread vascular permeability to the extent that the vital organs in the body can no longer receive an adequate blood supply. And this also can cause constriction of airways, and typically this is treated with an injection of epinephrine, such as what's in an EpiPen. And epinephrine reduces these symptoms through engagement with the alpha and beta adrenergic receptors. So here we have a couple examples of your immediate local immune responses. So I mentioned the anaphylactic response, which you can see on the far side, where we have IgE-coated mast cells in the circulation, and those cells will rapidly release their granules, which causes vascular permeability. You can also have allergen entry through the skin, which causes a local swelling response. Then in the mucosa, we have an inhaled response, so this would be something like seasonal allergies or hay fever. And in this case, the allergen is able to permeate through the epithelium and interact with the IgE on mast cells there. These mast cells then will stimulate allergic rhinitis or upper airway inflammation, which is characterized by increased mucus production and nasal irritation and swelling and things like sneezing. And finally, in the mucosa of the gut, we have a somewhat unique immune response where these antigens can pass through that mucosa, and this mast cell degranulation leads to symptoms such as increased gut peristalsis. So the gut will contract faster, and this moves food as well as allergic antigens through the gut faster, leading to abdominal cramping and diarrhea. So then late reactions actually typically depend on the dose and timing of the allergen. And they're usually caused by continuing synthesis and release of inflammatory mediators. So our very fast acute response is due to the initial degranulation by mast cells. However, these cells continue to produce these mediators that are in the granules. And in a late reaction, these mediators are continually released. Medications such as glucocorticoids can help prevent cell influx. So I mentioned eosinophils can release chemicals that induce mast cell and basophil degranulation. They can also release chemokines, which encourage more cells to enter the tissue. So glucocorticoids can present that influx. However, they are not able to block an acute reaction. Chronic allergic inflammation and chronic asthma can occur with edema, and we'll see some examples of that shortly. And these responses lead to gradual inflammation and tissue damage, followed by airway remodeling. So this is going to be an increased infiltration of different cells, as well as an increase in collagen deposition. So this leads to a gradual constriction of those airways. So in allergic asthma, this is a chronic inflammatory allergic response, and it's characterized by submucosal mast cell activation in the lower airways. So we talked about acute rhinitis, that's in the upper airways, such as the nasal passages. In allergic asthma, this activation and degranulation is occurring lower in the airways, so down in the bronchioles of the lungs. And this activation leads to bronchial constriction and increased fluid in the airways. So the airways will constrict and get smaller, making it harder to breathe and get in oxygen. There's also an increase of fluid secretion. And so chronic exposure and these chronic responses can then lead to hyperreactivity of the airway. So the airways can become more and more reactive to allergens. And this can also contribute to increased tissue remodeling. So this pathology is mediated by Th2 cells, eosinophils, mast cells, and basophils in the lung. These allergens can also actually directly stimulate the epithelium by engaging toll-like receptors. So these in particular can activate ILCs that are below the mucosa, which then subsequently release IL-4, IL-5, IL-9, and IL-13 are stereotypic Th2 cytokines. And this induces epithelial apoptosis and remodeling. And it can also induce something called goblet cell metaplasia. And this is where normal epithelial cells can differentiate and become goblet cells, which produce mucus. And this leads to a chronic increase in mucus in the airway. And we see that mice lacking Tbet, which is a transcription factor important for Th1 cells, can develop allergic asthma. And here, I've mentioned a few times this airway remodeling. This figure is a really good example of that. So on the left, you see a mouse that's positive or wild type for Tbet. And the normal lung is nice and open. There's the alveoli have a lot of space for gas exchange. And the normal airway is not very thick. However, upon, in this case, a knockout of Tbet, an increase in airway inflammation leads to more cell infiltrate, which you can see here in the airways. So these alveoli are now more filled with cells. Then over time, the airway can be remodeled, so more collagen is deposited, and this leads to a thickening of this airway wall here. And this makes it harder for gas exchange to occur. So now we're going to switch gears a little bit and discuss food allergy. So food allergy has some of the same systemic symptoms, but there are a few other gut-specific reactions as well. And food allergy can be IgE-mediated, non-IgE-mediated, or it can be categorized as an idiosyncrasy or a food intolerance. So idiosyncrasies typically resemble allergic responses in symptoms. However, the cause is usually unknown. And food intolerances are also not really allergy. They're non-immune responses and typically are due to metabolic functions. So a really good example of this is lactose intolerance. So in this case, an individual just lacks the enzymes to break down lactose. So looking at food allergy, interestingly, 25% of all food allergy is due to peanuts. And allergens, like those found in peanuts, are often resistant to digestion from enzymes such as pepsin, which is found in the stomach. And normal symptoms of a food allergy include local swelling, perhaps in the mouth, throat, or tongue, GI cramping, diarrhea, and vomiting. So this is that increased peristalsis I mentioned earlier. And systemic reactions such as anaphylaxis can occur when the antigen moves from the gut lumen into the blood. Okay, so we've talked about a variety of different allergies. What ways are people working to treat allergy? So our first category of treatment is with drugs that inhibit parts of the effector pathways. So these usually treat only symptoms of these effector functions. So the most well-known drug is an antihistamine, and this works by targeting the histamine 1 receptor and reduces symptoms that way after histamine release. In patients with allergic asthma, inhaled bronchodilators can act on beta-adrenergic receptors to relax constricted smooth muscle and help relax the airways. And there are also some new treatments now using monoclonal antibody therapy against IgE. This helps remove excess IgE from the body and downregulates the expression of Fc-epsilon receptor on mast cells and basophils. Another common treatment is called desensitization, or what you might know as allergy shots. So this treatment works by slowly increasing the dose of an allergen that's injected. These injections have to happen weekly or every other week, typically for about 3 years. So this is a very long process. And that's because these doses of allergen are very gradually increasing. And this helps shift the immune response from an allergic IgE response to more of an IgG response, which is less likely to cause mast cell degranulation. This can also induce regulatory T cells to secrete IL-10 and TGF-beta, which helps suppress that mast cell degranulation. A subset of desensitization reactions are acute desensitization. And this is in patients such as diabetics who require administration of insulin, but who may actually have an allergy to that essential drug. So this is basically an accelerated desensitization process. So we start, like with the allergy shots, here with an increasing dose of the drug. And they start with the lowest dose that causes no reaction. So you can give a very small dose, they don't have an allergic reaction. But then this dose is gradually increased every 30 minutes. So this is a much more sped up version of this process. And if a patient develops symptoms to a dose, then that dose is reduced back down to a level where allergy is not caused, and the process continues, slowly accelerating that dose over the course of a day. So it's thought that this can help induce subclinical mast cell activation. So this essentially means that the very small doses of this allergen can help release only a few granules at a time, or maybe only a couple mast cells will be activated. And this isn't enough degranulation to cause immune system symptoms. So this process is continued over time, allowing these mediators to be released very slowly. It also helps deplete the amount of cell-bound IgE. The one drawback to this response is that it requires daily drug administration to maintain the desensitization. So if a patient does not take the drug for a couple days, those mast cells will be able to build up the mediators in their granules, and again, they'll have an allergic response. So this is a clinical way to keep those allergic responses low enough that the essential drug is tolerated. Okay, so far we've discussed mostly IgE-mediated allergic diseases. So now we're going to go through a brief overview of a few non-IgE responses. So the most common is a drug hypersensitivity. And this is, for example, an allergy to penicillin, where the drug will bind to red blood cells, and the surface antigens that are bound by the drug will be targeted by an anti-drug IgG antibody, which targets those cells for destruction through complement or phagocytosis. And this eventually leads to hemolytic anemia. So these red blood cells are destroyed, and eventually they are low enough that anemia results. And in penicillin, interestingly, this drug can actually react with proteins on the cell surface and haptenate them. So it can alter them enough that the body no longer recognizes them as self. And then these proteins are the target of an antibody response, not necessarily an IgE response. So we've mentioned in previous lectures something called serum sickness, or disease caused by immune complexes. So this is also considered an allergic response, although not one mediated by IgE. So serum sickness, as we've discussed previously, is a response against non-self antibody that's injected in non-self serum. So, for example, for some diseases that are treated by injection of serum, for example, the recent Ebola outbreaks before the vaccine, patients would receive an injection of serum from an individual that had survived the infection. And this gives a boost of antibody that's thought to help that patient fight off the infection. And unfortunately, these responses can actually lead to a response against the non-self antibody that's injected. So these antibodies in the patient receiving the serum can bind to the non-self antibodies and create immune complexes. And larger complexes are cleared through complement or phagocytosis, but small immune complexes are often deposited on blood vessel walls. And this can cause tissue damage. So symptoms usually occur about 7 to 10 days after serum administration. And this is because the adaptive immune system needs some time to initiate an immune response. In some patients, we see urticaria that can develop, and this suggests that there's a role for histamine in these responses, although the mechanism of that is not entirely clear. And mast cell degranulation can actually be triggered by IgG complexes in this case as well. So one thing with serum sickness is it's typically a self-limiting response. And that's because a finite amount of serum was injected into these individuals. So once that serum, the antibodies in that serum, are cleared or removed, the allergic response will conclude. It will no longer continue because the antigen has been removed. So here in figure 14.17, we can see an example of this process. So here, locally injected antigen is injected into an individual with an IgG antibody against that antigen. These IgG antibodies can then complex with the antigen and activate complement, as well as lead to mast cell degranulation. So then we see a local inflammatory response. So because of the mast cell degranulation, we have increased fluid leading to swelling. There's also more protein release and phagocytosis. And this can lead to occlusion of the blood vessels, or these complement complexes can actually close off the vessels and not allow blood to flow. So here we see a graph of the timeline of serum sickness. So the yellow line shows the amount of foreign serum. So when this is injected, that goes up. And then there's a formation of antigen-antibody complexes. And this can lead here to a fever response or vasculitis, vascular inflammation, or arthritis or kidney problems. And then over time, as the adaptive immune response develops, the person will develop antibody against those foreign serum proteins. And so if the same serum is injected subsequently, this process will be sped up, just as would happen in a normal adaptive immune response. Another type of non-IgE mediated allergic disease is hypersensitivity that's mediated by Th1 or CD8 cells. And this is known typically as cellular or delayed type hypersensitivity reactions. And one of the best known examples of this type of reaction is called the Manto Test. And this is a test for exposure to tuberculosis. And people working in the healthcare field often have this test to see if they are carrying tuberculosis. So essentially what happens in this is a small amount of tuberculin is injected subcutaneously. And if the individual has been exposed to tuberculosis and has antibodies against tuberculin, there will be a local inflammatory response. And this typically develops over 24 to 72 hours and is characterized by visible swelling. And we'll have Th1 cells that enter the area and recognize the peptide MHC complexes. And this can lead to a release of inflammatory cytokines, which is what causes the test result, which is swelling. So if a person has been exposed to tuberculosis or the vaccine for tuberculosis, then they will have a swelling response. Another hypersensitivity reaction that's similar is metal allergies. So in this case, cations in the metal can alter peptide MHC complexes, and this leads to induction of an immune response. And interestingly, nickel, which is one of the most common allergies, can actually directly induce TLL4 activation. So here's an example of the Manto test. So we have our antigen in red here, injected subcutaneously. Then this antigen is processed and cytokines are released, which leads to vascular permeability and swelling at the site of the antigen injection. So this graph in figure 14.19 is a nice summary of these hypersensitivity reactions. So we have our delayed type hypersensitivity, contact hypersensitivity, and gluten sensitive disease or celiac disease, which we'll talk about in a couple slides.